Hello, my name is Sheila Castillo, and I am the Principal Investigator of the Center of Excellence in the Elimination of Disparities here at the University of Illinois at Chicago.
And my name is Amparo del Socorro Castillo, and I am the Master Trainer for the Midwest Latino Health Research Training and Policy Center.
The Center of Excellence in the Elimination of Disparities, or CEED Chicago, is a CDC-funded program, part of their REACH initiative. REACH stands for Racial and Ethnic Approaches to Community Health, and the basic premise of the REACH program is that communities must be part of the identification of the issues related to their health, and they must be part of the solution in determining how to improve the health of the community. Thank you for joining us for our presentation. The purpose of this PowerPoint is to show the benefits of community health workers on healthcare teams, both because they improve health outcomes and they help to control costs. These are two requirements of the new Affordable Care Act. This presentation came about to advance the CEED Chicago strategy to improve health literacy among Latinos and African Americans in order to reduce diabetes and cardiovascular disease. Community health workers are effective health educators and health promoters in these communities, and CEED Chicago is working to promote community health workers so that more communities may be served. We have 4 objectives for today. At the end of this presentation, we hope that you too will see the value of including community health workers as members of your healthcare teams. In speaking with physicians and administrators from federally qualified health centers in the preparation of this presentation, we learned that these 7 points were of their greatest concern. Behind these concerns are issues such as low literacy, lack of health literacy, limited to access to health information by patients, as well as a lack of awareness on the part of providers about the challenges faced by their patients. We also learned from our discussions, and we've seen in the media, that doctors and medical practices of all sizes are expected to do more with less money and less time. 2 issues that impact some of these costs are medical errors, and miscommunications with patients. We need to consider interventions that could overcome these communications issues to improve patient safety, assure more favorable treatment outcomes, and keep costs manageable. We need to think about community health workers.
There are many reasons why community health workers are important. One, they are our frontline healthcare workforce. They are out there in the community. They have an effective way of delivering public health messages, prevention messages to vulnerable population. The second piece is they are in the community. So they are a trusted member of the community. They have a better understanding of the culture in that community, and they can tailor their response to the needs in that community.
As Dr. Choquer said, community health workers are frontline public health workers. I would like to note here that while we refer to them as community health workers throughout this presentation, they go by multiple names, such as promotores de salud, health promoters, outreach workers, and patient navigators. Among other things, community health workers teach and educate clients, help them navigate the healthcare system, reinforce healthy behaviors, and translate medical language into everyday language. They're employed by community health centers, public health departments, community-based organizations, hospitals, and social service agencies. Community health workers serve mostly low-income and under-resourced community, but they would benefit any community. Community health workers interact with clinicians, patients, and the community. Clients are referred to them by medical personnel because community health workers can spend the quality time needed to explain treatment plans and instructions. Community health workers can also connect their clients with needed resources. We have seen community health workers have positive impacts on patients' health outcomes. I will turn this over to Dr. Castillo to discuss this point.
Now I want to share outcomes from community health worker interventions that improve hypertension, asthma and diabetes control, immunization, and breast cancer screening rates among patients. Most of these studies were randomized controlled trials considered the gold standard and conducted in both rural and urban settings. The Joint National Committee on Hypertension states that 30% of individuals with high blood pressure are undiagnosed. More than 40% of hypertensives are not receiving treatment, and among those who receive treatment, 2/3 remain without control. This slide represents the results from a randomized clinical trial of 421 hypertensive patients from low-income neighborhoods in Seattle, Washington. This study compared the traditional method of advising patients with the second method using community health workers. The first group was advised to have their blood pressure checked and was given a list of clinics where they could go. The group that interacted with community health workers was educated about hypertension and received reminders to have their blood pressure checked. The community health worker intervention resulted in nearly 20% greater rate of medical visit follow-up than the control group. Holyoke Health Center is a federally qualified community health center that serves 20,000 individuals, more than 90% of whom are Spanish-speaking, mainly of Puerto Rican descent, and most with family incomes below 200% of the federal poverty level. In 1999, they adopted an electronic registry to track diabetes patients as part of a larger effort to implement an integrated approach to chronic disease management. 30% of their diabetes patients had not seen a provider within the last year. So in 2003, they added community health workers to the diabetes care team to enhance the capability to engage and support patients who were not succeeding in managing their diabetes, patients with hemoglobin A1C levels above 9% who had not seen a provider in 4 months. This slide shows the changes in the clinic's population of patients with diabetes from the year 2000 to 2006. At the bottom, we can see the number of patients diagnosed with diabetes each year. The number increased from 169 in 2000 to more than 1,000 by 2006. The color bars represent the different levels of diabetes control. The yellow bar shows the A1Cs of less than 7%, which at the time was considered the goal of glycemic control. The blue bar corresponds to A1Cs between 7 and 10%, and the red bars are for A1Cs of more than 10%. To the left, we have the proportion of patients that correspond to each one of these 3 categories, and to the right, we have the range of A1C values displayed by the different groups. The blue dot in each one of the blue bars represents the average A1C value for the whole population of patients with diabetes at the clinic every year. We can see how the average A1C was progressively higher from the year 2000 until 2003. We can see how the average A1C was progressively higher from the year 2000 until 2003, when community health workers were introduced into the program and trained in the delivery of diabetes education. By 2003, the average A1C was 8.4%. Only 30% of the patients were considered under control, and 18.2% had A1Cs above 10%. After 2003, we see the continuous reduction of the average A1C in spite of the significant increase in the number of patients with diagnosed diabetes. The proportion of patients considered in control of their diabetes increased to 46.2%, while the proportion of those with extreme values significantly declined from 18.2 in 2003 to 10.8 in 2006. The implication of these changes include the reduction in the risk of complications such as blindness, amputations, kidney disease, and cardiovascular disease for all patients with type 2 diabetes receiving care at the clinic. The authors of the study credited the community health workers with forming valuable personal relationships with patients, while promoting self-management and linking patients with clinical care as the key to the health center's ability to connect with more patients with diabetes. This randomized clinical trial of 897 low-income and underserved patients from federally qualified health centers in Robeson County, North Carolina, aimed to improve mammography rates. The treatment group were assigned a community health worker that provided home visits and phone calls, individually tailored health education, follow-up and support to overcome barriers to make an appointment for a mammogram. The comparison group received reminders in the mail along with health education materials. The 12-month breast cancer screening rate was 15% higher among those women who received the community health worker intervention. The improvement was seen across all the three groups of women: African American, Native American, and Caucasian women responded equally to the intervention. CHWs, community health workers, have also been effective in improving immunization rates among children. This randomized trial with the goal of improving immunization rates among children was conducted in New York City. Community health workers provided educational referrals through phone calls and home visits to the children in the intervention group. This resulted in 75% of the children being up to date at their 6-month vaccination schedules, compared to only 54% in the control group. Compared to that control group, only 18% of the children in the community health worker group were late getting their vaccinations. The control group had 38%. This means that over twice as many children were late for vaccinations when the traditional method was used. Authors attributed the success of the intervention in part to the fact that the majority of the community health workers were bilingual and lived in the same neighborhood as their participants. The following are examples of clinical centers incorporating community health workers as members of their healthcare teams. La Clínica del Cariño is a federally qualified health center that serves minority and low-income patients in Oregon. The community health workers are members of the healthcare teams for two important programs: the Salud program, addressing educational needs in chronic disease, including hypertension, diabetes, and hyperlipidemia, and the perinatal program for women and newborns. The clinic conducted a program evaluation assessing the role of the community health workers. They found that community health workers significantly influenced case management activities in all service areas. 77% of their time was significantly dedicated to case management, with only 12% in administrative duties and 11% in transitions from one place or function to another. The results of their assessment showed how community health workers were included in the everyday activities related to education, individual care plans, the recall system, providing system navigation and social support, and participating in clinical procedures. In Laredo, Texas, the Gateway Community Health Center also makes community health workers an integral part of their structure, operations, and provision of services. The roles and responsibilities of community health workers are addressed in the clinic's policies and procedures. A system of performance improvement and continuing education ensures the strengthening of their community health worker workforce. A diabetes self-management program led by the community health workers is incorporated into patient care system. Community health workers provide referrals, update charts, and have input in patient management by discussing with physicians their patients' self-management issues. This chart depicts the flow of patients in the diabetes program. After the medical assessment, doctors provide some education and establish the treatment plan with the patient. Then, the patient is referred to the community health worker for their diabetes self-management education in groups. These 3-month courses have well-defined objectives and help the patient adjust to a healthier lifestyle. Community health workers work with physicians in helping patients gain diabetes control. In Chicago, we have several examples of the integration of community health workers in healthcare organizations. One example is Chicago Family Health Center. At this clinic, community health workers are responsible for marketing clinical services. They also recruit patients to programs and services, refer patients to primary care physicians, and follow up in the community those patients referred to them by the providers. Their positions are salaried and supervised by an administration.
Now that we've examined some outcomes from community health worker interventions and model programs, let's look at funding. As you know, healthcare is shifting to a value-based system that rewards quality care and positive health outcomes while penalizing negative outcomes such as hospital readmissions. We've seen that community health workers can increase quality and outcomes, but how are they funded? Many, if not most, community health worker programs are grant funded. This doesn't lend itself to sustainability. I'm going to present one possible sustainable funding stream. The Illinois Health Connect program under the Illinois Department of Healthcare and Family Services is an enhanced primary care case management model serving over 1.8 million Medicaid and state children's health insurance program recipients across the state. There are 5,700 primary care providers enrolled in Illinois Health Connect. It assists clients in selecting a best fit primary care provider or medical home. Illinois Health Connect gives bonus payments to high-performing providers who deliver certain preventive care services. These services include corticosteroids for asthma patients, immunizations for children, and mammograms for women over 40. Providers who hit a certain benchmark for delivering these services receive a bonus of $25 per patient. Depending on the size of the provider, this could be a significant source of revenue. This data is taken from a large federally qualified health center in a large city in Illinois. What you see are the actual payments providers received based on the number of patients who were treated for asthma, received a mammogram, and also treated for diabetes and immunizations. You also see the maximum potential payment they would have received if they succeeded in meeting the predetermined benchmarks. This FQHC received $11,125 for providing these services. They could have also received $72,500 in bonus payments. This revenue was essentially left on the table. In the past few slides, you have seen that CHWs made a difference in the number of patients receiving mammograms, immunizations, and seeking treatment for diabetes. It's clear that community health workers can help providers achieve their quality benchmarks. In this case, community health workers would have generated additional revenues, which in effect would have funded their salaries. Providers who are part of a network might also benefit from pooling contributions from bonus payments to fund a community health worker. This strategy uses potentially lost revenues that could be recovered through community health worker interventions to pay for community health workers. The added advantage is that the strategy comes with improved care coordination and patient outcomes. We've talked about patient outcomes and funding for community health workers. Now let's talk about community health workers' role in lowering the cost of health care. Community health workers are proving to be highly valuable in acute care settings, including hospitals. Emergency room visits can cost 3 times or more than a normal outpatient visit. Medicaid and uninsured patients are 5 times more likely to use the emergency room for an avoidable condition. Here are some examples of community health workers and the impact they have in these settings. The goal of Boston's Children's Hospital's Community Asthma Initiative was to reduce the number of asthma-related emergency room visits and hospital admissions. This intervention included community health workers and nurse home visits, home environmental interventions to reduce asthma triggers, and connecting them to community resources. At the hospital, community health workers' efforts decreased asthma-related ER visits by 62% and hospital admissions by 82% within a 12-month period. Also noted was a 40% reduction in missed school days and a 47% reduction in missed work days by parents and guardians. In Baltimore, community health workers conducted weekly home visits and phone contacts to activate and educate Medicaid-eligible African American patients with diabetes with and without hypertension. The results showed that total ER visits were reduced by 40%, total ER and hospital admissions were reduced by 33%. There was a 27% reduction in Medicaid expenditures. The average savings was $2,245 per patient per year, for a total savings for these 117 patients of $262,000. The potential gross savings per community health worker with a caseload of 30 patients was estimated at $80,000 to $90,000 per year. A study by Elizabeth Whitley evaluated the financial impact of community health workers on the Men's Health Initiative of the Denver Health System. The study developed a return on investment calculation for 590 patients. They looked at utilization, charges, and reimbursement for services between January 2003 and June 2004. The intervention increased primary care and specialty visits and reduced urgent care, behavioral health, and inpatient visits. This decreased total charges for these services by $300,000. Uncompensated charges were reduced by more than $206,000 in 9 months. This represented the difference in uncompensated costs 9 months before the initial CHW contact and the 9 months after the first contact. The total program cost for community health workers was $6,229 per month. This resulted in a return on investment of $2.28 for every $1 spent on the program.
Community health workers are used in a whole variety of ways, but one of the most important ways today is everybody's worried about how we control healthcare costs. Is there a way to bend the cost curve? Now, what we've seen here at Sinai Health System, and the Sinai Urban Health Institute, is by having community health workers who understand the disease process, understand their neighbors, understand their community, actually work hand in hand with those neighbors, lead them through the healthcare system, and help them at a very basic level change the way they live, the way they behave, the way they keep their houses clean in some cases with asthma, to really make a huge difference in the spending around healthcare. Very impressive and very powerful impact. If you want to translate that to dollars, this is very compelling and one of the best rates of return I'll ever see in my lifetime. For every dollar invested in a community health worker, we've avoided spending between $13 and $15, depending on the acuity of the case, in acute care services, ED visits, admissions to the hospital. And that doesn't count the time lost work by mom or siblings who are not going to school because they're all supporting the person who's in the emergency department.
This is a summary of studies at Sinai Hospital comparing community health workers' asthma education interventions. The interventions consisted of different levels of interactions, from asthma education to asthma education with case management. All of these interventions showed positive return on investment, with the largest ROI realized for the more complex and larger approach.
There are also emerging opportunities for the integration of community health workers due to the Affordable Care Act, including grants to fund community health worker positions for health promotion within medically underserved communities. This is just one example of the shifts occurring at the federal level in support of community health worker interventions. Other changes include the new code for community health workers under the Department of Labor, and the mandate to address diversity in the workforce and provide cultural training through the area health education centers.
Health care for an individual as well as for the population is improved by the team-based approach as suggested in the chronic care model, which means that it's not just about a physician or a provider alone being the sole giver of care, but the team that incorporates everything from social workers to nurses to mental health workers and others that can help meet all the needs of the individual patient.
As Dr. Galloway says, community health workers are a key strategy in current approaches to healthcare, including healthcare reform and medical models. They extend the reach of medical practice into the community where patients experience the majority of what influences their health. Let's hear their stories.
We really like what we're doing because we see the reaction for the clients after the class. That they go and shake your hands and say thank you because I didn't know a lot of this information because I know it's gonna help me a lot.
I think this is for my own experiences I can help with other people. You always say I do this, maybe you can do this. Like for example, before I didn't do exercise, and now I do everyday exercise. I take my daughters and dance with them for 30 minutes, and I started to cut like junk foods. I don't buy junk foods in my home. Before I buy, but now I don't buy. I don't have a junk food, and then I change my home a lot. This is I told to them if I can change it. For sure, you can change it too. Yeah, this is what I'm telling to them.
So, what we have shown you is that community health workers have the potential to strengthen healthcare delivery by enhancing the connection to patients and continuity of care, which can improve quality, utilization of services, and reduction in costs. In closing, here are a few basic steps that you can take toward implementing community health worker interventions in your practice. Please feel free to contact us for referrals to successful programs. Here is our contact information. These are the researchers leading these efforts and the organizations involved. This includes the Center for Disease Control and Prevention, CDC, through the Racial and Ethnic Approaches to Health REACH US initiative.
And we would like to thank the members of the Physicians and Administrators Presentation Subcommittee for their contribution to this effort, and to all of the members of the Community Health Worker Committee for their participation in the development of this project. Thank you.
Please refer to this list of articles in the literature in support of the material that has been presented. Thank you very much.